This is going to be a talk that I've done a little bit before, but it's primarily for those of us in the community, and it's trying to raise awareness for what is frontotemporal dementia, what is FTD, what are the different clinical syndromes, and then maybe some ways to sort of manage some of these issues. So we're going to go through it. We have a pretty ambitious schedule because we only have 30 minutes, and I don't want to take any time from Dr. Gonzalez because she's going to give a great talk on dementia of Lewy bodies. So we'll go ahead and get started. So dementia, it's an umbrella term, right? Everyone talks about dementia. People talk about Alzheimer's disease. They say, oh, you know, I have dementia, but I don't have Alzheimer's disease, so it's great. Or I have Alzheimer's disease, it's not dementia. Really what it means, dementia, all it means is you're having significant changes in cognition, changes in thinking that are affecting your ability to live independently. So your memory is so poor, you're forgetting to take your medications, and then your blood pressure skyrockets. That right there is the diagnostic criteria for a dementia syndrome. Now, underneath that umbrella, we have all these different types of dementia. So the one we hear about most often is Alzheimer's disease, and that's affecting a huge portion of the population. The one I'm going to talk about today is frontotemporal dementia. And that's a much smaller population, but it can be a much more devastating disease course. So here is a picture of the brain. I realize we give all of these talks and we talk about parts of the brain and we don't ever, or a lot of times we don't really go over the basic anatomy. So what I'm talking about is the frontotemporal dementias. And is there a way to, oh, there we go. So this is your brain. Over here, these are where your eyes are going to be. This is your temporal lobe, sort of near your ears. This is the back of the brain. So the frontotemporal dementias are just like it sounds. They're affecting the frontal lobes and the temporal lobes. And those are areas that are in controlling, you know, motor and speed and memory and language and judgment and executive functioning and all sorts of areas. So now that we've seen the brain, let's talk a little bit about terminology. So I want to make sure that you guys understand the difference between a clinical syndrome and then the suspected neuropathology or the disease process, because they're not always the same. When we talk about a clinical syndrome, we're talking about a constellation of symptoms. So a patient comes into the room, what do I see? What symptoms are they describing? What am I seeing, you know, on examination? And what am I seeing on the testing? Those symptoms, a lot of times, will hang together, and that will let me know what the clinical syndrome is that we're dealing with. Now, the underlying pathology, those are the bad proteins that are sort of building up in the brain. And where they build up in the brain dictates what I see on exam. So if there's bad proteins building up in the temporal lobes, that's an area that's really vulnerable or really important for learning and memory. So if the bad proteins are building up there, we're going to see deficits in learning and memory. If the bad proteins are building up in the frontal lobes, we're going to see different types of symptoms. And so it's important to differentiate between the clinical syndrome and the disease pathology because a lot of times they mimic one another, but they can be different disease processes. So you can have someone who on pathology will have something called plaques and tangles. And that's what's usually implicated in dementia of the Alzheimer's types. There's plaques and tangles in the brain, and they're going to affect memory, but sometimes they don't. Sometimes they'll affect other parts of the brain, and so you'll have what looks like a clinical syndrome, or maybe a frontal syndrome, but you go to pathology and it's plaques and tangles, so it's primarily Alzheimer's disease. All right? So it's confusing because really there's no consistency in the terminology. People talk about AD or Alzheimer's disease, and they can be talking about the clinical syndrome or they can be talking about the underlying neuropathology. People talk about FTD, and the same goes. They can be talking about one of the clinical syndromes or the underlying pathology. So it's important to try and tease them apart in your brain. So the frontotemporal dementias, these are a cluster of neuropsychiatric syndromes. Remember, the syndromes are just another cluster of symptoms. And they arise from neurodegeneration of the frontal and temporal lobes, like we talked about, so these areas. Whereas Alzheimer's disease is affecting more of the posterior parts of the brain as well as the temporal lobe. But you'll see there's considerable overlap between the two. FTD is the most common form of dementia for people who are under the age of 60. Average onset is someone who's between 45 and 64. Almost certainly, there are people who are going to be younger and older. Gosh, you guys are getting a lot of sun. I'm sorry. So it can be quite devastating because these are individuals who are sort of in the prime of their lives, right? You're midlife, you're planning to work for another 20, maybe 30 years, there are kids at home, and then the illness strikes. And then the caregiver is sort of, caught in this squeeze where they're taking care of the patient and then taking care of the household and the family. So it can be particularly hard and have really lasting impacts on the family unit. And I think that's one of the reasons I'm really drawn to it is because, we're here to help treat the patient, but we also need to treat the family and not forget what's going on there. So we talk about that. Another issue is that, the life expectancy is about 7 to 13 years after symptom onset. So this is oftentimes a much more aggressive course, but what makes it challenging is that it's frequently misdiagnosed. On average, it takes about 3.5 years before a patient gets an accurate diagnosis. And when we're dealing with a more aggressive, faster disease process, that's 4 years that are sort of, spinning your wheels trying to figure out what's going on. So our goal, I think, is to raise awareness of these frontotemporal dementias and ensure that the community recognizes it and other providers recognize it, and we can recognize it earlier in the disease process. So now we're going to go into the different phenotypes or clinical syndrome. And so each FTD phenotype has sort of a prototypical presentation, and that's thought to reflect the distribution and accumulation of the pathologic changes in the brain, so those bad proteins building up. Okay. So here are the clinical syndromes. So the one we hear about most often is called Behavioural Variant FTD. And this is a syndrome affecting behavior, affecting personality, affecting judgment, oftentimes affecting motivation. But we also have these other two down here, which are the semantic variant and the nonfluent agrammatic variant. Now these two separate and come over here, and with the addition of something called the logopenic variant, these guys make up the primary progressive aphasias, all right? So they're essentially, a way to think of it is the language variant of frontotemporal dementia. And they each have different symptoms, but they're all sort of classified under the FTD umbrella. But it doesn't just affect behavior, and it doesn't just affect language. We also have motor variants, so patients who are having difficulty controlling motor, so their movements. We have patients who will have FTD with motor neuron disease, so that's frontotemporal dementia with ALS or Lou Gehrig's disease. We have patients with cortical basal syndrome and patients with something called progressive supranuclear palsy. Now, these last two are thought oftentimes considered to be Parkinson's plus syndrome, so they sort of start to look like Parkinson's and then can change. But for pathology-wise, the FTD people have adopted it, and so it's considered part of the motor variant of FTLD. To make it trickier, this non-fluent agrammatic, you might start off with some language problems, some difficulty making speech, difficulty getting your lips to formulate or produce the words that you're trying to say, but then it can evolve and move over into one of these more motor variants. So the motor dysfunction is not just affecting your speech, but it's also affecting your body movements. Okay, And so here is just another representation of what we just talked about. So with the family of syndromes, we have the behavioral variant or behavioral variant FTD, and that is usually predicted by impairments or atrophy of the frontal lobes. See that here? See how the rest of this is nice and plump, and this is a little bit smaller. Then we have the semantic variant of the primary progressive aphasia, and that is characterized by atrophy here of the temporal lobes, often the anterior temporal lobes, which is really important for language. And you can sort of see a comparison here, how this one is much more plump than this area over here. Oftentimes it will affect the left side more than the right side. Left side is usually, for 95% of the population, the dominant hemisphere for language. But you can have it flipped. And then for the non-fluent variant of primary progressive aphasia, this is affecting an area up here. It's sort of the motor. A lot of times people talk about it, about Broca's area. Has anyone heard that before? But it's sort of a motor area in the brain, and it's an area that dictates how the motor movements involved in creating speech. So it's not necessarily a loss of language. It's difficulty in formulating speech or getting your mouth muscles to do what you want them to do to get the words out clearly. And this is my favorite slide of all time, because up here we have the clinical syndromes of FTD. So we have the behavioral variant, we have the semantic variant, we have the non-fluent variant, we have the motor neuron disease, cortical basal, and the progressive supranuclear palsy. Now down here they have something called frontotemporal lobar degeneration. So this is when you start getting into the pathology. And this is when we're going to have Dr. Walker over here looking at brain slides, and Dr. Bieniek, I always say it incorrectly. They're right back there, though, our new neuropathologist. And they're going to look and take slices of the brain and look at them under microscopes and try and figure out what bad proteins are in the brain. And as you can see, so with semantic variant, this is one that for the, 80 to 90% of the time, it's going to be a protein called TDP-43 type C. Occasionally, we'll have Alzheimer's disease, so the plaques and tangles that are building up in those language areas, and it will sort of mimic the semantic variant. And sometimes we have tau, but pretty rarely. Conversely, if we look at PSP, so that progressive supranuclear palsy, it's always going to be a tau, and they're calling it a tauopathy. And so this illustrates why it's important to really be precise in our clinical diagnosis and figuring out the clinical syndrome, because eventually, when our basic scientists sort of make those developments, we're going to be able to identify which patients are going to respond to which medications. So if there's a medication coming out that will sort of affect the accumulation of tau, and we have a patient with PSP, we know, okay, they need an anti-tau medication. All right, so the genetics of FTD, most often they're going to be sporadic. So these happen and we don't know why. But FTD does have a strong genetic component. And so about 40 to 50% of cases are diagnosed as genetic, and 10% have what is called an autosomal dominant pattern of inheritance. So that means if one parent has that gene, each child has a 50-50 chance of getting it. But I will say the ones that are most strongly familial are going to be behavioral variant and then the ALS FTD. The primary progressive aphasias, more often than not, are not familial. But then we also have mutations in tau, which is about 17% of patients, mutations in progranulin, and then the C9orf72 mutation. And this is about 13 to almost 25% of familial cases. And again, these are going to be patients with ALS, behavioral variant, or a combination of the two. Okay, so we talked a little bit about the clinical syndrome, and we talked a little bit about the bad proteins, and we talked how the bad proteins building up in the specific areas of the brain dictate what we see on interview. So for behavioral variant, the clinical hallmark, this is going to be changes in behavior and social decorum, all right? So a lot of times that's because we're seeing early atrophy in these areas, in these frontal lobe areas, and prefrontal cortex. And so because that's where the changes and the atrophy is occurring, we're going to have patients who are more disinhibited, saying things maybe they shouldn't say. That filter that we all have starts to disappear a little bit. You're going to see changes in personality. So maybe someone who was once very maybe reserved and proper becomes a little bit more loose, maybe making some bawdy jokes or saying things that are inappropriate. A lot of times there's a loss of concern for others and just sort of a lack of awareness and not responding as they once would to someone who is in pain or upset. Overeating. So I often ask if patients are eating more sweets, and if they're sitting down for a meal, are they eating more food? And if they do eat their food, are they starting to pick food off of others' plates? I think that's sort of a quintessential sign. But then there's also patients who have fad foods, so they don't want to eat anything. There's one patient I saw recently who just likes popcorn shrimp, and that's all he eats all day. And some people can get very ritualized about the types of food they eat and how they eat them. Apathy is a big one, and apathy just means sort of a lack of motivation, a lack of drive. Someone who was once very active and, participating in a lot of different, social groups, all of a sudden they just kind of want to stay at home, and they'll watch TV, they're fine. And it's not really there's no sadness involved, it's not really like a depression, it's just more this thought that I would rather just sit at home and not go and do those things. And then you have stereotyped behaviors. And so these are behaviors, oftentimes they're simple repetitive behaviors. So like clapping or slapping, picking, just doing the same thing over and over. A lot of times these patients will come in and the family will say that they're very anxious. And I'm like, okay, well, how do you know it's anxiety? And they're like, oh, it's just constantly moving. And you look at it and you see someone that it could be anxiety, but really it looks like restlessness. They're just sort of driven by an internal motor and they just gotta move. So those can be the early changes for behavioral variant, FTD. Now the primary progressive aphasias, these are a spectrum of language disorders. So in the variant provides clues to the underlying pathology. And so the term primary means that the language symptoms are going to be the first thing that we see, and they're going to be the most pressing. And so a clinical interview can really help tease apart what symptoms were first, and that's important because it helps us try and differentiate between what clinical syndrome and ultimately what underlying pathology is sort of driving this train. So we'll go from there. All right. And so similar to the behavioral variant, the speech and language disorders, where we see the atrophy in the brain dictates what we're going to see in clinic. So patients who have a semantic variant or semantic aphasia, they're going to have atrophy in that anterior temporal lobe. Patients who have something called apraxia of speech, they're going to have atrophy up here in sort of, the motor strip. So there is the atrophy, and where it is, can help us identify what we think is going on. But really when it comes to the primary progressive aphasias, what we're interested in is the fluency of someone's speech. And I like to think of them on a spectrum, right? So on one end, we have the progressive non-fluent aphasia patients. These are patients who are having trouble getting the words out. They make inconsistent speech errors. There are changes in sort of the prosody and intonation of their words, but really it's a motor disorder. Their lips will not do what their brain wants them to do. On the other end of the spectrum, we have semantic variant primary progressive aphasia. These are patients who start off and they're very fluent. They speak fluently, the pronunciation is really good, but when you listen to the language, you listen to the content of what they're saying, a lot of the times it's really empty or it's really vague. And so it can be difficult to understand what they're trying to convey. And I think this is one that is probably the most challenging to recognize. And usually when I'm in the room and I'm with a patient and they're talking and I think I understand, and then I just realize I don't know what we're trying to talk about here. And that's usually an indication that something is going on with language and we should look at it further. And then right in the middle is the logopenic variant. But because this is usually caused by Alzheimer's disease, I'm not going to spend a whole lot of time talking about that today. But logopenic variant is sort of in the middle. It's sort of this intermittent fluency. They have some word-finding pauses, they have some difficulty with pronunciation, and they're having a little bit of change in sort of naming. So those are the primary progressive aphasias. And so the hallmark for the non-fluent is this effortful, non-fluent speech with distortion of prosody. And prosody we think about as sort of the nonverbal aspects of language. So the inflections, and so if I end my sentences very low, or if I go up, and so it's sort of that rise and fall of your words. A lot of times these patients will have something called apraxia of speech, and so that's a motor speech disorder. And you can see it in other syndromes, but really apraxia of speech is that difficulty coordinating the motor movements. And a lot of times I elicit it by listening to someone say something over and over very quickly, and I want to see the kind of errors that they're making. Is it a consistent error, the same time over and over, or are they different errors? Are they inconsistent? And that can be really helpful. And then automatic speech. I want to see, can they count? Can they do the alphabet? And usually that's going to be more fluent. Those sort of overlearned things like singing happy birthday will be fluent than, just spontaneous speech. Agrammatism. This is something that is pretty helpful for diagnosis. Because they're dropping articles of speech. You're going to have patients who are a little bit more telegraphic. And that's because if you have difficulty getting the words out, you're just going to focus on the most salient words necessary to communicate, right? So we're going to drop the V's, we'll drop the A's, and really just focus on the meat of the sentence. And that's something called agrammatism. But typically, if you look at that in spontaneous speech, and then look at it you're going to see the same thing if they're writing or if they're trying to appreciate grammatical structure in sentences. So it affects all domains. So then we come to semantic variant. And this one, the clinical hallmark, is the fluent speech, but diminished conceptual knowledge. These are patients who have difficulty recognizing and sort of understanding what things are. Right? So if you lose the conceptual knowledge of what a fork is, and I show you a fork, you don't necessarily know how to use it or what it's for, right? So it's not that they can't think of the word, it's just that they've lost the meaning for what that word actually is. And that can be particularly dangerous because, you'll have an inability to recognize potentially dangerous situations, because if you don't know that a speeding car coming down the road is dangerous and you can't sort of remember the associations with that, you might step out in front of it. But you'll see a lot of interesting things. So they'll make what are called semantic errors. So saying, hand me that banana when really they're looking for an apple. So it's in the same category. It's a fruit, but it's not the right word. Now, we all do this to some degree just on a daily basis, but it's only when it becomes really problematic then we start looking for semantic variant. And it can apply to the ability to recognize objects or smells or sounds. So if you hear like a helicopter and you have a semantic variant primary progressive aphasia, you're not going to be able to recognize and sort of put that sound to the idea of a helicopter. And so it can be particularly scary and really disorienting for patients. We'll just skip through that one. I gave you a little, can it not go up? No. So this is a woman, it's on YouTube. but it's just a woman who's talking, and she's talking a lot, and she's saying a lot, and she's very fluent in what she's saying, but it doesn't really make any sense. And she also has sort of like restricted, conversational topics, like she's talking about going shopping a lot. So I'll just go ahead and we'll skip to that. So behavioral changes in FTD, you're going to see them a lot in the behavioral variant, and you also are going to see them a good deal in patients with semantic variant. Those with the non-fluent agrammatic variant oftentimes don't have really problematic behavior, at least not early in the disease course. So early on, you're going to have changes in the behavioral disinhibition, so talking to strangers, touching, walking naked, blurting out offensive statements. Oftentimes, I'll have family members say, like, it's really embarrassing to go to the store because my loved one, will see someone and say, oh, that person's really fat, or that person's really ugly. And it's, it's hurtful to that person, but also embarrassing, and so it can be problematic. You're also likely to see apathy or inertia, so giving up on hobbies, withdrawing from social gatherings, staying in bed watching TV all day, which in itself can be problematic over time, because really a lot of times patients will stop doing anything. And they can be difficult to get up and get ready and try and go to these medical appointments, or go to work, or go shower. You're also going to see loss of emotional reactivity or sympathy, so they're going to be pretty flat. If someone, I really will always ask if there's been a recent death in the family, and then see how did the loved one or their patient respond to that death. And oftentimes they'll be like, oh, he's really depressed. I'm like, how did you know? And they're like, well, he just didn't respond, or he didn't say anything, and he just sort of sat and looked. I'm like, is it depression, or is it sort of this lack of empathy and this lack of awareness? It's difficult to tease apart. We talked about the perseverative or stereotype sort of compulsive behaviors. So the pacing, the hitting thighs, the picking, the tapping. A lot of patients can be very routine bound, so they want to do the same thing at the same times every day. So get a little bit more sort of obsessive about that, and upset when that routine is disrupted. Dietary changes, so we talked about increased sweets, food fads, increased consumption, or restricted range of foods. So just like eating all the popcorn shrimp. And then oblivious to danger. We talked about how not recognizing the danger and not seeing, why they need to worry about it. But more often than not, the biggest thing is the lack of insight into these changes. And that's why I always ask patients coming to see me, I'm like, well, what's your perception? How are things going? And 9 times out of 10, they're like, things are fine. Like, she wants me to come, or he wants me to come. I really don't see a problem. And so, it can be a double-edged sword. On one hand, there's the patient is very content with the way things are. But on the other hand, it can be very upsetting and sad for the families. So, but because that limited insight, it is 100% important that I always speak to a family member. Because if I have a patient who's not endorsing any problems and everything is hunky-dory, I need to make sure that that's accurate. And so I need to talk to the family member, or someone who's with that person day to day, and I need to hear sort of, make sure that their stories coalesce, or if they don't, figure out sort of what's going on. And again, we talked about this. It's just sort of where the atrophy is dictates what we see clinically. So how do we recognize it? A neurologic exam. You need to see a cognitive and behavioral neurologist. A neuropsychological evaluation. You need to see a board-certified neuropsychologist, or someone who's actively in the process of board certification. And then neuroimaging, so getting some sort of structural imaging or functional imaging can be helpful. And so we do this really long clinical interview, and I want to talk about the symptoms, the onset, the course, examples, the severity. And then I want to put it into context, because it's not just the disease, it's the person who is experiencing the disease. And so what is this? What was their social history? What was their employment? Their pre-morbid personality. Is this someone who's always been really impulsive? Is someone who's always made sort of lewd jokes, or is this really new? I want to know their medical history, their psychiatric history. Are they using substances? And then sort of the stability of their living arrangements. Are things in crisis right now, or can we take our time with this? And then we're going to do some neuropsychological testing. And this is probably the most exciting part of the talk because I am the neuropsychologist. So what I'm going to do is I'm going to give a battery of tests, and we are going to measure different cognitive abilities, which sort of tap into the frontal lobes or the temporal lobes or the parietal lobes. And I can get a sense of how well that person is performing. And I take all of these scores and I do some really fancy statistics, and then I can control that patient to a normative sample. So a group of men or women of similar age, similar education, similar background, and sometimes I can even control for estimated intelligence, sort of your natural God-given abilities. And then I have a good idea as to where that person should be performing, and I can compare that to where the person is performing, and then I look for patterns. I'm not going to base it on one single test score. And then I'm going to send them over to the neurologist like Dr. Shashadri or Dr. Parker, and they're going to do a neurologic exam. And they always draw this little guide. I don't really know what it means, but I'm just kidding. They're going to check out, different areas of the body, their reflexes, gait, balance, strength, sensation, all the cranial nerves. And then, with the imaging, and if they meet diagnostic criteria, so for behavioral variant, if we have 3 symptoms of those behavioral changes, so they're more disinhibited, there's a lack of empathy, and the cognitive testing shows a lot of executive dysfunction, and then we have these types of images, that's going to give us enough evidence to make a probable diagnosis. But it's never going to be, I shouldn't say never, it's rarely going to be a definitive diagnosis unless there is, a genetic component, or we one day will get tau imaging or amyloid imaging, and then we can identify these bad proteins prior to death. So the treatment. Sadly, we do not have any meds available. No meds to cure, no meds to delay, but we can offer symptomatic relief. And so we treat all the other medical conditions like infections or Parkinsonian symptoms, seizures, pain. We review all the medications, reduce redundancy or side effect burden. So if someone's taking a lot of pain meds, that's not great for your brain, so we might want to taper those down. And then a lot of our treatments are non-pharmacological. So education, so helping patients and families and the community increase their tolerance for disruptive but perhaps non-dangerous behaviors. Hooking them up with services so they can get medical alert bracelets. So if somebody wanders or somebody is doing something inappropriate, they can sort of show their bracelet. A lot of families will bring along cards. And so if they're in a situation that becomes particularly sticky, they might hand the card to that individual, the stranger, to let them know that my loved one does have a dementia syndrome and some of his behaviors may, be inappropriate. Please forgive us. Providing distraction or redirection to curb behaviors, support groups for caregivers. I can't say enough about, the support groups and the networks and dealing with other families who are going through something similarly. And then the need for power of attorney and getting all of your legal documents in order. A lot of times these patients are younger, they're able-bodied, and they're restless. So we want to get them exercising and just expend that energy so they can sleep at night. And we want to ensure the good sleep because a lot of times that can reduce behavioral issues during the day. There are no evidence for any herbal or alternative remedies. Please do not buy anything that you see marketed well because there's nothing there. We can go to speech pathology. They also have interventions. We work closely with the aphasia lab down at UT Austin. And we talked about that. PT/OT and home safety evaluations. SSRIs seem to be sort of the biggest pharmacological treatment, and that can help with the compulsions, help eradicate those repetitive ritualistic behaviors. Trazodone can be helpful for sleep and controlling some of the behaviors. So, And then, I talked a little bit about genetics and genetic testing, and this is something I think it's important, who should be tested. Not everyone who has one person in their family with a dementia needs to undergo genetic testing. And always keep in mind that genetic testing has big implications not only for yourself, but your other family members. So really the only time I think we recommend it now is for someone who has a really strong family history, and that means 3 or more generations of disease. And then why get tested? Patients want to know, families want to know if there's any family planning, possible treatment options in the future, but we want to recognize what those results mean for other family members. So the big takeaway message here is that prior to getting any sort of genetic testing, please make sure you try and get genetic counseling. And I think that is a crucial element to any type of genetic testing. And then these are some clinical trials, but I think I'm running out of time. And so many, many thanks to all of our patients and families. Thanks to the Association for FTD and our colleagues at BIGS. And this is a picture from our first BIGS brunch. And you see we're a little group, but I think we've grown, like tripled in size by now. So thank you very much.